screening programme and the bowel screening programme.
Thank you.
Okay, so if we start off with cervical screening, screening is offered to women aged 25 to 64, either on a 3-yearly basis if they're aged 25 to 49, or a 5-yearly basis if they're aged 50 to 64. The programme aims to prevent the development of cervical cancer by identifying those who are at higher risk by screening for human papilloma virus infection. The women are invited by the national programme and they are asked to contact their GP practice to have a cervical screening test taken, and this is usually done by the practice nurse at the surgery or by a nurse at a local sexual health clinic. The sample is taken using a speculum and a cervical broom to sample cells from the cervix, and these are sent for examination by the primary HPV screening laboratory, which is based at Health Service Laboratories in Euston. And a woman will get the result of an HPV negative test within 5 to 7 days. And then they will be recalled at either 3 years or 5 years, depending on their age. If the HPV test shows that they have an infection with one of 13 high-risk HPV serotypes, they will be referred in for a colposcopy appointment, and that's an assessment using a microscope, a magnifying glass, to look at the health of the cervix. And for residents of Merton, that will take place at St Helier Hospital. One of the issues that we have for cervical screening, similar to breast screening, is that London has historically had lower uptake than the rest of the country. We are working closely with our colleagues in the Cancer Alliance in South West London to try and boost coverage for cervical screening. We have recently run 2 campaigns, one nationally and one across London, which targets those boroughs with lower uptake and also has been targeting social media channels for those women who do not speak English as a first language. And we're trying to do that to reduce the health inequalities across the system. We do monitor our services very carefully, and we have quarterly programme boards with the colposcopy services and with the laboratory. And we are pleased to advise you that the colposcopy service at Merton is achieving its standards for screening appointments for both those women with low-grade abnormalities who should be seen with it in 6 weeks, and those with high-grade abnormalities who should be seen within 2 weeks. And I think I'll probably stop there and take any questions on cervical screening.
Has anybody got any questions? on survival screening? Martin, did you have your hand up?
Can you just clarify whether all referrals are at St Helier Hospital? Obviously, there's 4 here, because I've noticed obviously Kingston's figures are very low in comparison to the others. What's the explanation for that?
The explanation for that, this you'll have seen the figures for the whole of London, is that we have seen this bulge in screening activity since the pandemic. We have also seen a significant increase in referrals for colposcopy following the implementation of primary HPV screening in 2019. And that's because it is a much more sensitive test than the previous cytology test. We've seen this increase across the whole of London. In South West London, we've seen around about a 50% increase in activity since 2019. Kingston have problems with capacity in terms of their clinic space and their staffing, and they have business case in with their trust and with the integrated the ICS to resolve those issues, which we expect to be resolved by the summer of this year. It appears that Epsom St Helier are managing their workload and their capacity very well. And yes, the majority of women from Merton would be seen at Epsom St Helier.
Anybody else?
Again, as getting back to some figures, my understanding is that Merton achieved 61% screening for cervical cancer. It's the lowest in Southwest London. Nationally, 68%. Havering got 71%. And that's for the younger women. For older women, we're 70. Only Wandsworth is lower, if I understood that correctly. Could you explain why the figures in Merton are so disappointingly low?
I think you have, during the breast screening session, answered that question. You have said that Merton is deprived. We know that screening uptake is better, again, in white, more affluent women. As I mentioned, we have run the social marketing campaign, which is targeting those boroughs with lower uptake. It is targeting those more deprived boroughs and targeting population groups where English is not their first language. So trying to address the inequalities issues that we know about. Unfortunately, because the campaign only started in February, we haven't seen any impact on coverage figures as yet, but quite happy to come back and report once we do have those figures. Coverage figures are about 6 months in arrears.
Anybody else? Can I just say that various areas are deprived. Communities that are not of white or of this country have been in this country for years. We cannot suddenly say that they're not getting the screening or they're not coming to the fore because of the community they live in. I mean, we use this excuse all the time. You know, we get fed up of these sort of excuses. We have to do better. We have to really do better to reach people and make sure that they get the benefit that others are getting. It's not because they're deprived or they're not getting the benefit. They're just not getting the benefit. That some of them are not being offered. So we have to do a better job of offering these people the same as everybody else is getting, and not to use this deprive, and of a neckness group. And people are people, women are women. We've got to do better instead of using this same old chestnut.
Yes, I appreciate that, and I do accept what you're saying, which is one of the reasons why we designed the social marketing campaign to target and try and encourage women from ethnic backgrounds to come into the programme. And yes, I agree that we should be doing more in local communities, using local community champions to encourage their peers into the programme.
Anybody else got anything to say? Lakshmi.
Can I ask what is being done to what programs exactly are you got in place to try and reach these women who are reluctant to come forward? Is it if you get sort of female doctors going out to talk to the communities to make them feel more comfortable about talking about something as private as this?
Yes, we do use members of that community, professionals from those communities to go out and talk to community groups. We also use community links, as has been discussed during the breast screening service, who do speak a variety of languages, so can communicate better with those communities than people like myself whose language is English. So we do try and use people from those communities to talk and encourage their peers to attend.
Thank you. Anybody else? No. Should we go on to the bowel screening, please?
Okay, thank you. The bowel screening programme encourages people aged 60 to 74 to attend for screening on a 2-year basis. This is the one cancer screening programme that screens both men and women. The individuals are sent an invitation explaining the screening test, and then a week later they are sent through the post a self-sampling device, which is designed for the individual to send a poo sample to the laboratory where it is analysed to find traces of altered blood. We have recently started inviting people aged 56 and 58 to take part in this programme. And the aim is that we will increase the target age group within the next 3 years down to age 50 to 74. If those individuals have a positive screening test, they are invited for an assessment to look at their fitness for examination through colposcopy. They will be assessed by a screening specialist practitioner who is a qualified nurse and who is trained in bowel screening and is trained up by the national programme. They will explain the consequences of a positive test and then, as I said, look at their fitness to go for a colonoscopy. They will have this appointment with the nurse within 2 weeks of their positive test. They will then go on for colonoscopy within 2 weeks of that assessment. And that colonoscopy looks at the health of the large bowel and will identify if there are any polyps which could then develop into a cancer. If there are any that are found, then they will be removed and sent for histology. Approximately 2 out of every 1,000 people that are screened will be found to have a cancer. And those are the sort of figures we would expect, and those are the figures that we are finding in southwest London. If an individual is found to have small polyps, which are not fit for removal, they are put on surveillance and they are screened on a yearly basis to make sure that those polyps do not develop any further. I think as we have said with the 2 previous screening programs, the one issue that we need to be addressing is that of uptake and coverage. However, having said that, bowel screening has seen an increase in coverage since recovery from COVID, and that's in the 50 to 74-year-old population. The group that we need to be tackling is the 56 and 58-year-olds. And mainly this is because the men in that age group have not been screened before. And so this is a fairly new concept for them. We do have issues, as we've said before, with some ethnic minority groups where the screening test itself is thought not to be acceptable. And we have been working with local faith groups and their faith leaders to encourage them to attend. Similarly, we are engaging with community links to call people who do not attend for their screening appointments to identify why they've not attended and to try and encourage them into the programme. And at that call, they can also re-request a screening test should it have not arrived through the post. And I think probably leave it there and just take questions.
Thank you. Anybody with questions, please? No. I would like to ask something. You gave a timeline as if somebody discovered to have polyps, and then it's like 2 weeks after, and then it's 2 weeks after that. They get to be seen by the doctor and they get things that. Can you tell me what year that was? Because now you can't get an appointment with the GP. So how can you go and see a doctor? It doesn't follow that quickly.
No.
Lots of people are struggling to get doctors. So how will that happen?
This is an automatic referral process through the screening programme. So if the screening test shows that there is altered blood in the stool, they will be automatically given an appointment with the specialist practitioner. And after that, they will automatically get an appointment for a colonoscopy. So they don't go back to their GP for referral.
It's automatic.
Yeah. It's the screening pathway.
Okay, thank you. Anybody else? Thank you very much for that, Maggie.
You're welcome.
We can now move on to the next. Health and care together. Yeah.
So thank you, Chair. So if it's okay, I'll introduce it, and then my colleague Gemma Dawson will kind of take you through the body of the presentation. Just going back to cancer. So I just wanted to kind of, from a local perspective, there was a couple of things that I wanted to pick up on. Firstly, estate. So there's no reason why we can't be working with Rachel around why the possibility of an estate in Merton, and I was emailing her to say, come and have a conversation. Obviously, there are workforce implications and restrictions on the service, but that's something we can look into. I think also just in terms of when we go back to breast screening, that site doesn't necessarily follow performance. So in the breast screening, actually, Merton's performance was better than anyone else's in South West London, and they've all got sites. But the really important thing is the health inequalities. The really important thing is that we dig underneath health inequalities, and we are understanding some of the barriers to access, whatever they are, and we're addressing those. And that's exactly what the health and care plan should be about. It should be about really embedding action and joint action across the council, across the voluntary sector, and across local health provision to really address health inequalities. And I hate the term, but level up services so that actually everyone has the same access, and that we don't think 70% is an acceptable performance target. We want 100% in some of these areas. So just to introduce Gemma, and without setting her up, we have undergone a kind of joint piece of work over the last year. Obviously, COVID had a big impact on that. But we are now at the point of bringing the health and care plan together. The health and care plan is not a standalone document. It should sit alongside the health and wellbeing plan from the local authority. It should sit alongside our Gsna and our public health information. And it really is a plan where we have identified things that we can do much better if we do them together. So that's health, social care, voluntary sector. So I'm not going to go into great depth because Gemma's going to kind of give you the overall summary, but I'll hand across to Gemma just to take the mantle.
Thanks very much, Mark. Hopefully everyone can hear me okay. Yeah. Yeah. So as Mark said, our local health and care plan is a plan that identifies our health issues which require health, social care, the voluntary and community sector to work in partnership to improve the health and well-being of all of our residents, and it is particularly addressing health inequalities. As Mark said, it's just one element of work that's being undertaken, and it really is just the priorities that we've identified that actually we can't do alone, and that we would have the greatest impact if we worked collectively. The plan is working to deliver a vision of working together to reduce inequalities and provide a truly joined up health and care services with and for all people in Merton so that they can start, live and age well in a healthy place. The plan is following a similar format to its predecessor in that it identifies the priorities under the life course areas of start well, live well and age well. And across all of those start well, live well and age well, we want to reduce health inequalities and embed equity. We want to use population health management approaches to drive change. So we want to look at the data and look at the collective impact that we can have on our population. We want to focus on sustainability and making Merton a healthy place so that we have the conditions for health and well-being to thrive. And we all, in everything that we do in the plan, we want to engage with our communities, with the service users and the people that use our services so that all our work is developed with and by the people in Merton. So I'll just give a couple of headlines on some of the areas that we're focusing in our plan over the next 2 years for Start Well, Live Well and Age Well. So for Start Well, we're really wanting to be focused on mental health and well-being. We're wanting to look at different ways that children and young people can access mental health services and to be more preventative in our approach. We're particularly looking at integrating some of our community, primary care and hospital services and looking at developing more localised clinics in community settings. We're also really putting a spotlight on delivering our Child Healthy Weight Action Plan and looking at trying to expand some of our successful social prescribing programmes in the east of the borough for children around weight management, so to particularly target some of the obesity issues. In Live Well, we want to look at how people access services and to innovate and try and improve access to particularly address health inequalities that we know around access. We're looking at piloting a health on the high street approach, working with our fixed assets of 7 libraries, and then also setting up pop-ups across the high streets across Merton, exploring how we can use those different formats to provide different ways for people to access early prevention services around mental health, and also, again, to cast a spotlight on some of the fantastic community and voluntary sector services that are already available that are perhaps not accessed by all. We're also looking at setting up a project to better understand some of the health inequalities that people might face in access for mental health services, particularly looking at some of the ethnic disparities that we have there. And we're really wanting to work in and develop partnerships with our local community sector and voluntary sector to try and look at how we can address those disparities. And then with our primary care networks and our GP practices, we're looking at setting up a series of group consultations, primarily for people who are at risk of or already diagnosed with diabetes, and or for new mothers or new parents, to try and help people connect and come together, and also to provide a different way of offering services through group consultation in their local practice in their community. In Age Well, we're tackling a huge project to try and challenge ourselves to be more integrated and to join up, particularly around our frail population. So we're trying to connect up some of the services we've already got to try and make it more holistic and more of a seamless experience for people. We want to tackle some social isolation and digital inequalities to try and again help people who might be struggling with some of the technology or having had so many services moved virtually over the last couple of years, to try and build and tackle some of the information and digital inequalities that we've got, to try and build connectedness and tackle some of the social isolation that we know is there. This is just a flavour. I've just highlighted a few, but in your pack on page 80, there's a table for each of the life course areas, which goes into more detail of the projects that we're planning to undertake, the outcomes and the impacts that we're hoping to tackle. Just want to say that this plan remains dynamic. We want to be constantly in dialogue and conversation with our local communities, and also for other priorities when they come on board, so that we can be flexible and change and incorporate them. And also we want to really kind of continuous improvement. If something's not working, we want to flex and change and move that around. Our plan builds on a predecessor plan that started in 2019 and ran for 2 years. We learned a lot in how to deliver and implement that, so we're informed by those things. We want to manage this plan through our local partnership board, Merton Health and Care Together, and where we monitor progress and get updates on a monthly basis. I'll pause there and just see if there are any questions or other areas that members of the committee would like me to speak more on.
Are there any questions? Martin?
Yeah, I think there's obviously one thing that I obviously have picked up looking at this plan is obviously in relation to dementia diagnosis. The numbers have fallen. Is there any statistics on this? Because obviously this is quite concerning, but also as well the people who do need support services then from the council.
So anybody else with another question?
I mean, it's an impressive and large list of areas to look at. I'd be interested to know what you might consider to be the particular priorities.
Would you like to answer those, please?
Yeah, I can take those 2 questions. So we haven't got anything, just firstly on dementia, we do monitor the dementia diagnosis rates as part of our wider performance metrics. And so I'll definitely take that query and that challenge back and make sure we can get some information to you, so we can give you the update on what they're doing around making sure that those diagnosis rates are tackled and get back to where they need to be. And although we haven't explicitly mentioned people with the dementia in our plan, absolutely supportive, and are working with the local dementia hub in Merton, particularly through some of our community and voluntary sector work, and picking up on some of those bits within Age Well. So thank you for that, and it may well be that we should have some more conversations and strengthen that element of our plan. The second question around the ambition and scale of our plan, I think is testament to all of the stakeholders' true commitment to wanting to use this as a vehicle for change. I think some of the projects are actually already in motion, and they're a continuation of some stuff that had already started from either the previous plan or were part of it, and we're using it, the profile of being part of this, as to help it and as a catalyst. Some of the projects are new, and I think it's important to note that we've developed, and the local authority and the CCG have both invested in this plan and this group, and we've got some project managers, so some dedicated resource to help make sure that we can honour our commitments that we've stated in this plan. Hope that answers your question.
And if I could just support Gemma in that, I think just in terms of the number of priorities, there was a big engagement kind of last August, September, October time, where we asked local councillors, we asked our voluntary sector colleagues, all our stakeholders, actually, what were your priorities? And actually, this is the priority list. It's not, we're not going to then pick another set of priorities within this list. These are our priorities to work together on. And I think also just in terms of what COVID has taught us, COVID taught us that actually, whether it be in the people most affected by infection, or indeed those that took up the vaccination, that we had to deliver services, we had to deliver health messages in a very different way. And that's be led by the communities that are across Merton, and actually really listen to what people wanted and listen to what their barriers were. So I think that the really exciting thing is about, now that we are in a new administration, we are in the integrated care system, we can really drive ahead with this plan. So I'm genuinely excited about getting on and starting to deliver quite a lot of it.
You mentioned in the plan about housing. Housing in Merton is of good quality. However, there are high levels of overcrowding in East Merton. We know in East of the Borough that the housing, social housing in particular, is of poor quality. Can you please take that into consideration when you're looking at this and the consequences of that for the people who live there? Thank you.
I think the simple answer is yes, absolutely. And I think the thing about the integrated care system is it challenges us within health to work beyond health and actually look at the wider determinants of health. So we know that, you know, poor housing, the impact on health is massive. It's the same with salaries, isn't it? It's the same with wages. That's going to have a big impact on your health. So although, and goes back to Gemma's comments about the dynamic nature of this plan, we want to deliver and develop this plan as we go through, but absolutely take that into account.
Anybody else? Caroline? I thought you were fixing the thing earlier on. No. Right. Thank you very much for your report. It's interesting. I hope that it reaches the level that we want it to reach, and we don't start and not finish. I know we will try, but I'm sorry to say, but we tend to see all these things too often. So let's make it work, really work for the people of the borough. Thank you. Dagmar.
Okay, good evening. I hope you still got the stamina for the last report. I try to keep it short. So I have presented to you a report about the Joint Strategic Needs Assessment. This is a statutory duty of the Health and Wellbeing Board, and the purpose really is that the partnership has a common understanding of the population health needs. And the overview and scrutiny had asked specifically for me to bring our emerging findings and describe the process a little bit, so that you can all be engaged earlier on rather than later when we have a sort of almost finished product. And that's what you see today. Now, it is really important to understand, it feels a little bit head to toe. We've talked about the strategy, and now we're talking about the underpinning data. So it would be more logical to start with the data, but life isn't neat. We all know that. So therefore, neither the strategy nor the joint strategic needs assessment, so our constant looking and checking data and epidemiology, is a one-off process. It is an ongoing undertaking. And the duty, though, is that once a year we present a sort of snapshot. Yeah, so that's how it works. And again, you will not be surprised. We try to get a bit of congruency into the whole strategy development and the underpinning data. So we've structured them again. You will get a bit bored, but start well, live well, age well, in a healthy place. It is not ideal because you can immediately think of things that go right through, so it's a little forced. But to make it easier, we have adapted the approach. So you can then translate back. We had the discussion around dementia diagnostic rates, for example. Yes, that will be picked up in age well, for example. So an attempt, albeit imperfect, to help you a little bit. Important to understand as well the limitations. So the Gsna really uses population health data. It's not about service data in the main. Only where we absolutely have no population data, we sometimes use available service data as a proxy for need. But you will see that the main data we use is really epidemiology about risk factors and diseases and mortality. Very, very important. You've heard it in many of our discussions that looking at the data is one thing. It is not the whole story. So a lot of importance is also played what is the actual experience of people. And both coming together then will inform what type of strategy and approach and service model will be developed. So the Gsna, though, is the data side. And what we wanted particularly for you to do, the way we try to sift through all the data is twofold. So there are evidence-based robust data sets. The public health outcomes framework is one. We've automated that quite a bit. You have it as an appendix, and that will give you traffic light type indicators. Now, it is a good way to sift through, but one has to avoid jumping to conclusions just because something is red, and being fine just because something is green, because you can be green because you compare yourself with all terrible others, then that's not good. You can be red simply because the numbers are so small that you have random fluctuation. So it does need work rather than jumping to conclusions, but it's helpful, and you have it all in the appendix. And what we then do is sift out, and I've given you in table 1 our sort of what we call key messages, headings, and we ask people like you, our big steering group, our stakeholders, whether this chimes with what they experience. Yeah, so it's checking the face validity of what we have filtered out. And that's the purpose why we bring it to you today. So is there something screamingly obviously missing? Are there things that you think, oh, you know, old stuff, why do we still drag it along? What you need to understand, and it was interesting to listen to the previous discussion, that the joint strategic needs assessment, the trickiest bit is the strategic. It's not what to include, it's what not to include. So if you come and suggest lots of other things, then I also would urge you to say, what can I take out? Because otherwise we will not have a concise, manageable amount to concentrate on. We will drown in everything. Yeah, so that's a tricky bit, but that's why you and the stakeholders and our people we test this out are really, really important to check whether we've got that sweet point between being comprehensive enough, but not drowning in everybody's pet idea. And it is very, very important if a topic is not in the strategic needs assessment, it doesn't mean it isn't important. It just hasn't made it into this summary. Now, the strategic needs assessment, we're concentrating on the summary at the moment, but there are other products. So if our overarching summary makes us curious, if something isn't right, if we are not sure whether we have actually grasped the meaning of data, of trends, we can then say, aha, this is important enough for us to dig deeper. And then we're prioritizing more in-depth work. Very importantly, we are also producing ward profiles, and some of you as some new councillors might find them helpful. They are summary of sort of basic demography and population health data by ward. So I leave it there. The main table is 2.92, so it's a bit at the back. And as I said, it is the Merton population first. You can't have a needs assessment without demography. You need to understand, is the population growing? Is it shrinking? Birth, death, all that stuff. Then we must cover the pandemic, although at the moment we are all here back to so-called normal, but there's a lot of impact that we need to be aware of. And then the now familiar start well, live well, age well. And obviously for us in the council and in public health, in particular important, in a healthy place. So we heard some of you mentioning housing. Of course, housing is such an important determinant of health. So the Gsna will describe the housing. Very important also to understand that the Gsna is descriptive, it is not prescriptive, because the people who look at the data and listen and collate haven't really got the legitimacy to then say, what are we now doing? Their task is to inform others like you, to then come up with a strategy where judgment always has to come in, because we can't do everything that's laudable. So I leave it at that.
Great. Any questions, please? Martin.
Yeah, I've just got obviously a few questions. Firstly, obviously on the ward profiles, obviously use census data is about to start hitting us from, we believe, June, because we know that some of the information in that dates from 2011, and obviously as soon as this information is readily available, I believe it will be later this year, that information is obviously distributed to councils. I'm also aware some of our wards have shifted in terms of their overall makeup as well, and we've had some completely new wards like the Wandle ward in Wimbledon. The other question, obviously, in looking at statistics, and I was looking obviously at the obesity statistics, they date from 2019 to 20. Obviously, that's 3 years ago. That was obviously pre-pandemic. When will these figures next be updated? Because I'm conscious that some of the figures here are now a few years out of date, and it would be obviously interesting to see what trends are in terms of that, given that it's a major challenge, especially in many parts of the borough, but in particular in the east of the borough, where we know there is higher numbers of obese children. Obviously, some of that is down to education as well, but also as well income as well in terms of food. I think it would be helpful to know when that they would be updated in terms of those statistics.
Shall I answer now, or do we collect any more? Shall I now? Thank you. Yes, absolutely spot on. So first of all, in terms of the changes of the ward boundaries, you will find in the report that we describe a little bit. It is particularly relevant for our East West comparison, and we obviously wanted to look over trend over time as well. Are we actually doing anything to reduce inequalities? You will see how we pragmatically have reallocated the change in boundaries, and the new Wandle ward. Wandle is counted as West.
Can I just say that, I mean, the U Wandle ward does create quite a large pockets of deprivation in terms of East. So obviously I'm surprised it's been allocated to the West instead of the East, because it really should be, I think, on the East in many ways, Wandle.
Yeah, so I don't want to, you know, become too techie. I think there are points for and against. We have consulted quite a number of, you know, the more techie people. We wanted to be as pragmatic as possible, because if we do more changes in terms of allocation east to west, the trend analysis is problematic. But if there's anything else that you suggest, one can have some other ideas, do let me know, and we can consider. The other thing around data and their sort of update of data, God, that's the bane of my life, having, you know, hot off the press. So I am dependent on others to produce the data. I'm not a primary data producer myself. So I'm in the hands of others. Be assured I pester them as much as that is appropriate to my job, but my hands are tied. So the moment we have shareable, updated data, we will use them. As I said before, the JSNA as a sort of product, as a snapshot in time, will freeze data, but it doesn't mean that we then close our eyes and wait a whole year. We are scanning the whole time. The moment new data come in, we use them. Yeah. Yeah. To be honest, Martin, it will be useful in a lot of other things. Obesity particularly, and we are after there is an obesity observatory. So when the childhood measurement program reports, we try to get as much data as possible and as granular as possible. So be assured that we're on it, and I can share some more in-depth data, because particularly around healthy weight on children, you will be aware it's one of our big priorities. So we've done some more deep dive on that type of data, all totally spot on.
Any more questions? Sorry, can you tell me who are the group for the Gsna, and how does Scrutiny fit in to the board, and how can we support, or how can we scrutinize, or how can we help?
Yeah, so so this is one session. If you have a look at the table one, even once you've gone home and you have a bit more time to scan it again after this discussion, you come across something in your constituency, in your surgeries, that you think, let me check out, have they picked that up? You can always contact me so that we have a bit of a rapport. And as I said, it doesn't matter that it isn't completely in that moment in the JSNA, but it is a process, it's an ongoing process. So that's one thing. You've got in the appendix the actual officer stakeholder group. And then we've gone through various community groups. We want to make sure that our voluntary sector can access the data as well as input, because the JSNA has the two purposes that we want other people to be aware and know about the borough, but equally tell us if they know something that we don't, so that it is a sort of a mutual process. And we are there. You know my face now, and there's an annual process.
Thank you. It's good to know, so the councillors know they can come to you anytime. Right, the recommendation that we're supposed to
So let me just go back, as I'm not using paper. Please congratulate me to that.
A, B, and C.
There are. So you note the purpose and scope so that you just understand what the Gsna is and what it isn't, that you review the key issues. Yeah, that was the table 1292. Come back either now or even when you go home and have a brainstorm, then let me know. If there's something, because obviously we are bound a little bit in a process because it needs to be published, etc. But if there's something new coming up that you want us to consider for the next planning round, please let us know, because the Gsna, honestly, it is quite a lot of work and we want it to be useful. So anything that makes it accessible and useful. So for example, this time around, we've also changing the format so that it is web-based with web pages. It's easier to manage than a huge big document, but comment back. Yeah, on all of those things, comment back and let us know if you've heard other people using it, because we want it to improve on all along.
Are we okay with the recommendations? Yes. Okay. Peter seems very stunned that there's no volume. They just nodded. Yes, so that your former chair, cabinet member, can feel secure.
Yes.
I was going to ask him to speak earlier, but I think he can now have a few minutes to say something, because since he sort of was our chair and left, and he's now the cabinet member, maybe you can say a couple of words and see whether he thinks we're going where we need to go.
Chair, those of you that know me will know that I'm a man of few words, particularly at this time of night. But I have been, I am the previous chair of this committee. I think those of you that are new to the committee will find that the work is really important work, and the scrutiny of health is, and adult social care is absolutely vital. And I wish you all well. And I have taken on this new role, so you'll be scrutinising me as well, and I'm sure you'll give me hold my feet to the fire whenever you feel it's necessary. But that I don't mind, because what you do is really important, and I wish you the very best of luck.
Thank you. Right, so we'll now go on to the work programme. Stella, over to you.
Chair. This short report is just an opportunity for the panel to finalise your work programme for the year. We've gone through a process. Where at the beginning of this year, between January and March, we collated a long list of topics for the work programme. That long list was presented at a topic selection workshop in June. And from that discussion, we now have a short list of prioritised topics which are to be agreed tonight. And then I will work with the departments to draw up a work programme for each item, setting out when it will come back to the panel, and I will bring that draft work programme in September. And just lastly, to say that the work programme is flexible. Within the health sector, issues tend to come up throughout the year, and you might need to move things around or change your priorities or ask someone to come along for a particular item. And so we try to build in flexibility for that. And it's with the agreement of the panel and the chair, you can move things around as you see fit. Just to say that the suggested task group for this year is support for people with autism. So if you agree with that as the task group, then members will be invited to join that review, which will begin in a few weeks. Thank you, Chair.
Thank you. Do we agree? Oh, yes, Martin. Yeah.
Obviously, I think it's very important that the scrutiny panel does have a full update in terms of St Helier Hospital. I'm very concerned, obviously, at the escalating costs and the project scope in terms of St Helier. And I think it is time that we do have the relevant people in that we can scrutinise and ask questions of. And I ask that this be on the agenda for the next scrutiny panel, given the implications it does have in terms of the borough. It's an important issue, especially in the east of the borough. And I would ask that we could have all relevant people and we could do a full scrutiny about what is happening on St Helier, because I am concerned as well about the escalating costs in terms of that project and the potential cutback from government as well in terms of hospital projects. I think it is important that this panel is obviously engaged in that. I think obviously the other one as well is obviously the Wilson development, but also as well alongside that, the Mitcham health and well-being. Obviously, it was mentioned earlier in one of the earlier reports as well. I think we obviously do a scrutiny do need to examine, because I am concerned as a Mitcham councillor about the number of years that the Wilson scheme has been delayed, and it seems to be consistently kicked in to the long grass. And there has been also various ideas floated around about the health and well-being hub, and I think it would be helpful if scrutiny did look at that, maybe not at its next meeting, but obviously sometime this year, because it is important to many people living in the borough, but also as well, especially in terms of access to healthcare in the east.
I think that's part of the program, isn't it, Stella? It's part of the program. It's close to all our hearts, and we're definitely going to make sure that it's,
Both those items have been mentioned to be put in the work program, but not necessarily for September. What I'll say about the Wilson is that there was an update just before, at the end of the last municipal year, and I'm not sure, I can refer to Mr. Kuhlman, but I'm not sure if there's much more to update for September.
There is an update on the East Merton Health and Wellbeing Hub going to the Health and Wellbeing Board tomorrow, which indicates that, and I don't think it's a secret, that indicates that the Wilson is the preferred site. It's identified that we've gone through a due process to get to that decision, and now we're at the process of writing an outline business case for submission. So it has progressed. We are currently working with the Mental Health Trust around what services may be delivered from there. But certainly we, as it's on the work plan, we can certainly bring an update. Things will be moving over the summer.
be great. Yeah.
Important St Helier is brought along to the next September meeting. We do need to have a discussion as a scrutiny panel on that.
Can I ask how that would fit in with the, because I know Merton Vision are moving to the Wilson while the doctor surgery is being built at Merton Vision in Collier's Wood. How does that fit in with the development of?
So I think in terms of, so the decant, the new Wilson will be after the decant, and Merton Vision going back into their new site in Collier's Wood, if that makes sense.
Thank you. Anybody else? No?
Yeah, can I just ask for clarification on the St Helier item? Councillor Welton mentioned having the right people attend, and I would just like for some more information about who you would like to see.
We'd obviously want the relevant people from the CCG, but also as well St Helier. I think it is very important for this scrutiny panel to be asking the questions that need to be asked, obviously, about this project, because I am concerned, obviously, about cost escalation. I think it has to be a priority for the next panel meeting.
And shall I respond? So I just think that in terms of the CCG, the hospital program is under a different kind of program of work. So I can absolutely speak to them and ensure that they're coming. I've got slightly worried that it's with the national out of the hospitals program. So it might be a relatively short update in terms of what they're getting fed back, but we can certainly ask for them to come along and present to you.
I think we do need all relevant people, and obviously I'll circulate anything outside of this meeting as well, but there does need to be that full update.
Right, anybody else? Thank you. I'd like to thank you all. I'd like to thank, have they all gone, the NHS and everybody that did the presentation. Thank you all for your hard work. And let's hope that we're going to make things work. We won't be here next year repeating the same thing.